So this whole concept of what could possibly be tipping them over the edge was interesting. So we did have available to us all of the toxicology, and we divided the different drugs into classes and pulled out all of those classes which had some impact on the respiratory or neurologic system. So antidepressants we know can have a sedating effect. Benzodiazepines, obviously, antipsychotics, particularly some of the novel antipsychotics, do have some sedative effects in some cases, anticonvulsants. And then we went to the over-the-counters as well, antiemetics, antispasmodics. So what you can see here is that a large proportion were on some type of antidepressant. 40% were taking a benzo at the same time. About a quarter were on an antipsychotic, 20% on an anticonvulsant. And the anticonvulsant is actually what's recommended in the context of neuropathic pain. So drugs such as gabapentin or others. What was interesting is people do ascribe alcohol in many of the cases in the literature, and that was not the case. Only found in 16% of our overdose deaths. So really this was, we think, more about these other classes of drugs that patients were on than alcohol or some of the other risk factors. So then it got even more interesting because we dug deeper and we found that over 90% were on at least one other class of drug. 70% were on two classes. About a third were actually on three classes in addition to opiates. And then there was this fascinating collection of cases where they were on four classes plus an opiate. Then, if you look within each class, there were a significant number of people who were on more than one type of opiate, and again, a number of people who were on more than one adjuvant within a class. So there were people who were on 14 different medications. And in the States, they call this drug stacking. We call it polypharmacy, which means somebody comes in with their chronic pain, and it's sort of the picture in our minds. They're prescribed an opiate for their pain. If there's a neuropathic component or it's back pain, they may add an anticonvulsant. They'll manage the comorbid and often symptom of depression. They'll add an antidepressant. The person may be having trouble sleeping, so they'll add some type of sedative for nighttime, and they're on enough drugs that they might feel a bit nauseous, and the patient may go to the pharmacy and pick up an antiemetic, and the pharmacist may recommend an antispasmodic. And so people were found to be on multiple medications all at the same time to deal with their issue. And this is just another description of the polypharmacy. And again, this was using our look at our drug database results. And again, this is where we saw that of those cases we were able to pull this database information from, only about a third were on a high dose of opioid. So that reassured us what we were finding in toxicology and in the coroner's notes were in fact probably right or true. So the conclusions we were able to draw at this point were that high-dose opiates, that is more than 200 milligrams morphine equivalent of prescription, is not necessary for an overdose death. And I think that's what surprises clinicians the most. We do know that in the early part of the last decade, overdose was certainly dose-related. It also showed us that in interior health, and probably the rest of BC, we've done a reasonably good job of pushing down that the use of opiate medications down to a dose where, in fact, it does make a difference and can help. That said, overdoses are still happening. So we attribute this to the use of adjuvant non-opiate pain medications that combine with the opiates to create a neurotoxic / respiratory impact and contribute to the overdose death. So the next question was, well, what to do? So last October, when we came to these conclusions, as a medical health officer, one has to act. So we informed our provincial health officer, we formed our BC Coroner, we informed our College of Physician Surgeons, we informed the College of Pharmacists in British Columbia. And then we thought the best way to target individuals would be actually through their GPs who were prescribing, through their psychiatrists who may be contributing to some of those prescriptions, and also to the pharmacists that were filling them. So we faxed information to all of the GPs, psychiatrists, and pharmacists in interior health and shared this information.
Dr. Corneil, we seem to have lost the connection again. Can you start from the slide again?
And we also decided
Dr. Corneil, can you hear me? Dr. Corneil, can you start from the slide again? We seem to have lost your connection.
Sure.
Thank you.
So from this slide here?
I think so, yes.
Okay. So actions. So as a medical health officer, we have to take actions when we see that something is going wrong. So our public health intervention was to inform the Provincial Health Office, the BC Coroner, the College of Physicians and Surgeons, and the College of Pharmacists. We also decided that the best way to access these individuals who might be taking multiple medications for their pain would be through the GPs and the psychiatrists and actually the pharmacists who are dispensing. So we faxed this information out and emailed this information out to all of the local physicians and all of the drugstore chains, as well as some of the private individual drugstores. We also, through the same route, gave the clinicians patient education tools to distribute to support individuals who were dealing with chronic pain, letting them know that they needed to take their medications carefully, not to take extra medications, and suggest they engage in a conversation with their clinician around being on as few medications as they need to be, but that decision needed to be made with their clinician. And then in the context of what is now being piloted in Ontario and several places in the States, a naloxone opiate overdose prevention pilot where those who are using illicit opiates, family, friends, people that they know are given a kit where they can inject naloxone and call 911, much the way one uses an EpiPen or epinephrine for allergies. We ask that our Center for Disease Control broaden their pilot to people who are also dealing with chronic pain. And we've been quite successful in actually moving some of this out into some of the GP offices as well as to one of our local prisons, so that when people come out of jail with chronic pain, they actually have a kit in case they decide to buy some medication, or a physician puts them back on the same prescription that they were before, and they may have lost some of their tolerance while in jail. Other things, we continue to look at the gray literature. We've been finding a lot of interesting information. People are contacting us with studies and overviews of coroner files that are very similar. They all stop at what is the cause, why are these accidental doses happening? And so we seem to have a partial answer to that question. We are trying to actually get a review, and we're having some success through all of the different mechanisms in British Columbia to actually have a review of all such deaths in the province. That will increase our N from 110 to 300-400 in any given study period, so that we can be more reassured of our findings. We're also planning on implementing a Sentinel emergency room overdose surveillance program, similar to the ones that we have for illicit drugs, so that we can try and capture some of the people who almost overdose, and see if we can't sort out or tease out some of the associations. And finally, of course, as any good medical health officer must do, any public health program, we want to actively monitor new cases and evaluate if there's been a change both in risk factors and in the rate. So the limitations, we talked about the accessibility to this PharmaNet history. That's our drug database in British Columbia, which is very complete, but was not always in the coroner's file. So we were only able to use it as something to validate. We actually would like to get PharmaNet history on all 110 cases so that we can really look at not so much prescribing habits, but what dose of drugs people were being prescribed, so that we might be able to identify one particular class, or perhaps one particular set of medications or classes is most risky to be on. Talked about how we're only able to, as an interior health medical health officer, extract our own data for residents in our own region, and that certainly has to do with restrictions on data sharing between government agencies and health authorities. And of course, one would love to do something more interesting, like a case control cohort, either retrospective or maybe even prospective. But privacy laws limit access to people, significantly to people who are alive. One is able to access information on people who are in fact deceased. And the ethics of this would certainly be something to consider. So in summary, in answering the question who, consistent with the literature, we found there was a lower age, that there was chronic pain, that there were comorbid mental health disorders. What was different from the literature was interesting. Higher proportion of accidental versus suicide, far fewer cases where high-dose opiates were involved, low unemployability or disability, almost no Aboriginal persons. Alcohol contribution was quite limited, and this was the part that we thought was interesting, is there was negligible multi-doctoring. So that led us to the question of how. So how is this happening? How are these accidental overdose happening? 93% of the cases polypharmacy seems to be the consistent factor that was found on postmortem toxicology. Why interior health? Why are we higher? We actually aren't able to answer that question because we can't compare. We've looked at different hypotheses. The only one we can come up with is that perhaps we've done such a good job of implementing the guidelines for lower dose opiates that we're seeing a reaction to the implement of those guidelines, which is overdose from polypharmacy. But there's certainly nothing conclusive at this time. And finally, what can we do? Well, with this information, we can educate patients, we can educate providers, and let people know that accidental overdose deaths do occur. And this is the important piece. People need to know that deaths can occur at any opiate dose, and if they are going to occur accidentally, they usually involve multiple medications.